And of course, it gives me great pleasure to introduce Professor Tony Holland, who you all know. Tony is the Emeritus Professor of the Department of Psychiatry in the University of Cambridge and a consultant psychiatrist. He previously led the Cambridge Intellectual and Developmental Disabilities Research Group. Since his retirement, he's continued research in PWS, and he has been the wonderful president of IPWSO since 2016. So Tony's going to speak to us tonight on behaviour and mental health. Thanks, Tony.
Thank you very much, Georgina. It's a pleasure to have the opportunity to do this. I want to start by saying that, of course, if you'd asked others to do this talk, other psychiatrists or psychologists, you might have got a rather different picture, although I think increasingly our understanding of the mental health conditions of people with Prader-Willi syndrome is coming together with some sort of common agreement. But these are serious issues, and for this reason, the International Prader-Willi Syndrome Organization has set up a mental health initiative, and we're bringing together about 50 people and parents from across the world to really explore this. And my talk is going to be slightly influenced by that. We've had our first meeting, which was really very, very informative. I also want to start by saying that, of course, the focus is often on impairments and disabilities and things that go wrong and problems that people have. But I want to acknowledge at the beginning that, of course, people with Prader-Willi syndrome also have great strengths. It's just that, like anyone in the medical profession, we get asked to see people when things have gone wrong and they need help. So the focus of a talk such as this is going to be, in a sense, on the negative aspects of things, but I just wanted to acknowledge the strengths that people with Prader-Willi syndrome, and particularly their families, illustrate time and time again. It's very difficult to know how best to focus a talk like this, because I think one of the struggles with mental health is that there isn't, in a sense, always an obvious treatment. And in a way, this has, I think, come up in the chat box and in the discussions we had in our small group, that there are many different approaches and many different things that can be done. And so what I've decided to do is really take you through a journey, which I'm going to try and describe how we are beginning to understand some of the mental health problems, rather than necessarily focus on treatment, because I think it's impossible to focus on every aspect of treatment or every possible problem that someone might present with. Rather, if you can understand the principles behind how you think about the issues, then in many ways, the answers are obvious. And so that's going to be my focus. And I'm going to have really three objectives to this presentation. I want us to sort of think about definitions of mental health and the terminology used to describe what at the moment I'm calling mental ill health in people with Prader-Willi syndrome. I then want to move on and think about some of the causative mechanisms for mental ill health. But as you will see, the model that I'll be proposing is very much one of thinking about what you might call the biological vulnerabilities that come with having Prader-Willi syndrome, and the context where they are living, as well as both their early environment as well as their present environment. And it's this interaction between vulnerability and environment that I think is so critical in understanding the mental health and behavioural needs of people with Prader-Willi syndrome. And throughout the talk, I'll try and touch on what I would like to think of some of the best practices in the assessment of mental ill health and in its prevention and treatment and promotion of well-being. But as you will appreciate, there are no obvious or straightforward answers over this issue. One of the things that's been very important, and this I read this in preparation for the IPWSO Mental Health Initiative, was really to think about how we define mental health, and particularly how we define it in this population of people with Prader-Willi syndrome. And I think it's really important that we have moved away from seeing mental health as more than just the absence of mental disorder. And the World Health Organization, in its documents discussing this, really thinks of it, I think, in a more, perhaps a more functional way, but it's really looking at how the individual can live and survive and thrive in the context of the demands of the environment where they are living. It's about having this dynamic internal state or equilibrium, the ability to maintain what they describe as harmony, to be able to recognize, express, and control and modulate their own emotions, and the ability to cope with adverse events and function socially. And of course, if you look at that definition, you can see that there are a number of ways in which people with Prader-Willi syndrome are compromised in terms of their mental health. So the concept of maintaining equilibrium in the changing environment, for me, I think has been really important. So good mental health requires the development of the necessary cognitive, social and functional skills to be able to negotiate through life, and children develop and become adults and develop those skills. But also it requires the ability to regulate their emotional and affective states. And I want to just mention here two broad and rather complex, I think, theories that, again, I have found have really influenced the way I think about mental health in people with Prader-Willi syndrome. And firstly, that I think we need to think that feelings and behaviors, so by feelings such as hunger, anger, happiness, sadness, these are as much as part of homeostasis as any more physical aspects of the way the body responds to the environment. They are, in a sense, telling us and helping us think through how we resolve a particular condition or state that we are in at the time, or particular circumstances. So for when you feel hungry, you seek out food, and that is to maintain homeostasis. But I think a second theory that I think is really helpful here, and when you begin to think about people with Prader-Willi syndrome, you can realize in a way what a disadvantage they are at. That if you think about the brain and the nervous system as, in a sense, the decision-making organ of the body, that it is dependent very much on internal, so inputs from the gut and the heart and so on, as well as external sensory input to develop and maintain an update of the model of the world. And this is work of someone called Carl Friston, among many others, what's called his predictive coding model and free energy models, in which he says what the brain is doing, the brain can't possibly spend a long time analyzing all the information that is coming into it any one time. What it's doing is it develops this internal map, which it updates depending on the sensory inputs, and then it responds accordingly. And again, if you think about people with Prader-Willi syndrome, you can think about the disadvantage they're at, because their inputs, both from the internal states, such as feelings of hunger, as well as from, for example, being able to appreciate someone's facial expression and what that means, may all be compromised. So the internal state, the internal model they have of the external world may in itself be a very incomplete model. So there's these two components that I think are helpful in thinking about the mental health needs of people with Prader-Willi syndrome. So then you can turn to the literature, you can say, and this will be very familiar to all of you, what are some of the particular behavior problems and mental health problems that are so specific? They're not unique to people with Prader-Willi syndrome, but they occur in excess in people with Prader-Willi syndrome. And of course, there's the emergence of the hyperphagia in early childhood, which will vary in degree. And I think it's very important to not think of these things as all or nothing. These are dimensions. So some people will have a very severe hyperphagia, and others it will be less severe. The same will be true of repetitive and ritualistic behaviors. And I use that phrase rather than obsessive compulsive disorder, because I don't think it's obsessive compulsive disorder. Then perhaps the most challenging and one of the most frequent issues has been the emotional or temper outbursts, and skin picking, mood disorder, and then psychotic illness, and which is probably more common in people with the UPD form of Prader-Willi syndrome. Then, in addition, as mentioned earlier, there is, of course, the cognitive profile, intellectual and cognitive profile of people with Prader-Willi syndrome that is going to both impact the way they see the world, but also the way they can communicate with and respond to the world. So the starting point here in thinking about mental health is really to think about the atypical development of people with Prader-Willi syndrome. And this is just some examples really of impaired development of the ability to regulate food intake in line with energy expenditure is an obvious example and a very striking one of people with Prader-Willi syndrome. You and I can control our food intake to match what we require on a daily basis. That's not possible for people with Prader-Willi syndrome. The break to their eating behavior seems to be impaired and in some cases almost absent. Their ability to respond to threats in an efficient and appropriate manner. And I use the word threat here. It may be a perceived threat, something that we wouldn't even notice, but it could be a change, an unexpected change in the environment, which may trigger an emotional outburst. Or their ability to manage to regulate their mood in response to life stresses. And then, of course, a very obvious, more physical one is the ability to regulate their temperature in response to environmental change. So the point I'm making is that these behavioral regulations are in a sense equivalent to a temperature regulation. We can understand it and appreciate it's about it. This is the case with temperature, but it's also the case with mood. And then you have the impaired development of those cognitive skills that allow this accurate and efficient model of the external world to be developed and updated over time. Now I want to now move to some of the specific behaviors and just mention some of the research that has been done. There isn't time, of course, to go into this in detail, but I've tried to pick on a few examples just to sort of illustrate the way I think our thinking is moving towards understanding the mental health needs of people with Prader-Willi syndrome. And if you take temper outbursts, I think what is very striking is that the work that's being done is really illustrating that these outbursts are very characteristic in how they present, how they're triggered, their course over time, and how they resolve. So it may be triggered by what's described here in the paper by Lauren Rice, by some sort of blockage of something they wanted to do, some perception of injustice or difficulty dealing with change. And interesting in this paper, she reports that actually medication, although used, seemed to be of very limited value, and that the thing that seemed to work most, and I think this would be generally our experience, is being able, if this is possible, to give the person space and distract them. So one of the key aspects in approaching temper outbursts is to understand these triggers, but also to develop and agree a strategy for how you manage them when they do occur. So you're going to try and prevent them by understanding them, but you also have a strategy in place for managing them for when they do occur. And this is one of Kate Woodcock's, and Kate's on the meeting I noticed today, Kate Woodcock's work. And I think her work is really very insightful because what she does is look in great detail at individual cases, individual people. She may follow up a video and look at and analyze what is triggering a situation, relate it to some of the cognitive impairments, particularly the issue of change, being able to cognitively cope with unexpected change. And by doing that, to actually understand the relationship between environmental challenges, if you like, and the cognitive ability of the person and the ability of them to respond under those particular circumstances. Now, the fact that the temper outbursts or emotional outbursts seem to have a similar pattern would suggest that whatever is causing them across the population of people with Prader-Willi syndrome has a similar etiology. Obviously, there will be differences in terms of what triggers and so on, but the general principles will be similar. And that's very important because it suggests that the interventions will be, can be similar. The principles that guide intervention will be similar. And here I just show our own work on the use of vagus nerve stimulation. And I'll just talk you through that in a minute. But the point about this slide is not so much that it seemed to work in 4 out of the 5 people, but that it is telling us something about the mechanisms that underpin temporal outbursts in people with Prader-Willi syndrome. It's telling us something about the importance of the autonomic nervous system and perhaps about the parasympathetic and sympathetic balance. And these are the individual scores on outbursts. On 5 people, we had 6 in the trial, 5 completed it, and 4 of them over, and this is the white is the baseline, and then this is 3-month intervals. And you can see in 4 of the people over the year of wearing the external stimulator, the behaviors went down and down. And it was actually really rather dramatic and very exciting to see. And 3 of the 4 people are continuing to wear the external stimulator that is shown here with an electrode that stimulates the auricular branch of the vagus nerve. 3 of the 4 are continuing to wear it and doing extremely well, whereas they had serious behavior problems before. And one of them is stopped using it, but is applied to have an implanted stimulator. Now, again, I want to emphasize the point here is more about what it's telling us about causation. And I know in Kate Woodcock's one of her papers, she talks about how some of the psychological interventions, the mode of action may be ultimately through the impact of changing the parasympathetic-sympathetic balance. So how do we now understand repetitive and ritualistic behaviors? So I think one of the things one can argue that maybe the propensity, the likelihood of ritualistic behaviors, for example, are due to developmental delay. You see repetitive questioning, very similar to what you see in young children. But they may also be related to temporal outbursts because of impaired attention switching, and that repetitive and ritualistic behaviors becomes a strategy used by people at the time of some demand or crisis. But also that there is emotional dysregulation, again, consequent upon autonomic nervous system dysfunction. I think one also has to take a much longer term perspective and recognize that behaviors will be altered and shaped over time. And this is where the perspective of applied behavioral analysis becomes very useful. So it's both about understanding the particular behavior, but it's also understanding how behaviors might be shaped and be changed and modified over time. So your assessment is really going to look at these different perspectives, and the interventions may include some functional analysis and looking at behavioral and environmental interventions. Kate is working on improving attention switching through training. You're going to treat any comorbid psychopathology, such as a mood disorder that may be present and aggravating the behaviors. And then ultimately, one's looking to whether strategies that in fact have an impact through the autonomic nervous system, whether very physical, things like vagus nerve stimulation, or psychological may be helpful. Now I want to just focus on skin picking. And again, it's not possible to spend a long time of that, but the same issues apply, or the same that apply to emotional outbursts. In that I think now what we see is we know that the skin picking or the self-injurious behavior that you see in people with Prader-Willi syndrome is of a very particular type. It is, picking the skin, usually from a spot, a pre-existing injury to the skin, often in the particular places on the body. It may, in its more extreme situations, include things like rectal picking. But I think, again, another principle here is that the way you think about skin picking is that there is a propensity, there is a risk, a biological vulnerability to it, but there are strong environmental contingencies that influence the extent of whether skin picking occurs or not. And this is the work of Scott Hall, and these are 8 people with Prader-Willi syndrome, and he looked at the rate of skin picking under certain environmental conditions. So this is a functional analysis, and essentially what he found is that skin picking much more commonly occurred at times when the person was being ignored or was alone, rather than when they were in situations of demand. And of course, that immediately then helps you think about how you might alter the environment in terms of trying to reduce the skin picking. You may not eliminate it, but you might reduce its severity or its intensity and frequency. He also interestingly did a very nice brain scanning study that looked at how this was associated with activations of areas in the brain that are known to be activated by sensations such as itch and pain. This is a review that Joyce Whittington and I did on skin picking. So as I say, I think we best understand the skin picking as this interaction between biological vulnerability and physical and psychological factors and environmental circumstances. So the behavior may be shaped by circumstances over time. It may be worse if there's a mood disorder, but it is also very environmentally dependent. So you need to look at, in this particular person who is skin picking, what factors, what conditions in the environment are associated with increased or decreased skin picking. You may well also be that itch is important here. So are there topical treatments to the skin that might reduce itch? And of course, one of the challenges here is that where you have a high pain threshold, there isn't any negative feedback. And of course, there have been trials, for example, of acetylcysteine, which modifies the glutamatergic pathways in the brain. Whether or not that actually helps skin picking, I think is still open to debate. And I think at the moment, we can't say that we have a medication that can definitely improve skin picking. It's much more about understanding the individual circumstances in that person. Now, I want to move very quickly to this contrasting situation. So things like emotional outbursts, repetitive and ritualistic behavior, skin picking are, if you like, behaviors that are present often from childhood and continue over time. But the striking thing about mental illness, and this is the thing that should alert you to the possibility of mental illness, is the development of an abnormal mental state. And this was the last person that I saw who I felt had a serious mental illness, in which it occurred very quickly. You know, it may not always occur this quickly, but literally this was over hours. And someone from the care organization that was supporting this person is on this call and on this echo. And so she, I know, will remember him very well. But within a matter of hours, he became bewildered, confused, anxious, unable to talk coherently, referring to blackmail, and so on. And you can see on the slide some of the other things that he was doing. And he was seen in the accident and emergency department, and they thought he had a confusional state. At one level, not necessarily a very wrong diagnosis, because the striking thing about him was confusion, which generally isn't associated with psychosis. And although he seemed to get better and was discharged, very quickly he deteriorated. Eventually, he was actually started on aripiprazole and improved. And I think he's had one or two minor relapses. This was now some years ago, before I retired. Had one or two minor relapses, but in generally has done very well. So the point about a psychotic illness is that it's a new phenomena. It results in some change that wasn't there before. So that's really very, very important. And this is the work that we did some years ago that seemed to suggest to us, and there have been about 10 studies, or 9 of them have supported this, that suggests that psychosis is much more common in those with UPD compared to those with deletion. Now, if that is the case, and there are 1 or 2 reports, and Georgina was mentioning earlier that that doesn't appear to be the case in the clinic she works in Australia. But if that is the case, the importance of this observation is it's telling us something about underlying mechanisms, and probably the fact that different genes and possibly maternally expressed paternally imprinted genes on chromosome 15 may be important, because those genes will be overexpressed in people with UPD compared with people with the deletion. So mental illness presents with a deterioration of behavior and the onset of new bizarre behaviors. It's, in my experience, quite often acute, but I've certainly seen people in which it's gradual. You get this abnormal mood state, and your interventions are largely in that acute phase. quite appropriately here based on medication, but also things like trying to lower the demand, keeping the person safe, and providing informed, consistent support to both the person with Prader-Willi syndrome and the family and those who may be supporting them. And sometimes, if it's very serious, admission may be necessary. Now, to end, I want to move to much more to the idea of formulation, because I want to return to this issue that it's difficult to give clear advice that if this is present, this is what you do. It's much more about how you make sense of this particular person's behavior and mental health or mental state in the context of both knowing about Prader-Willi syndrome and then knowing about the individual. And I think one of the things to think about in formulation is that, of course, what will bring someone to services, and particularly to psychiatrists, is what is observed by others. So their temper has deteriorated, they're agitated, they're self-injuring, or whatever it is. So this is reported by others or observed. What may also be observed, but maybe a carer infers or believes to be the case or is assessed, is whether their emotional state, are they happy or sad? That may not necessarily be apparent, but you need to ask about that. But it may also include things about, are they, then you may move on and ask more details about their mental state and their cognitions. So how do they describe and believe their mental state? Are they depressed? Are they have abnormal mental experiences, and so on? Clouding of consciousness, there where its consciousness is affected, may indicate a more of a physical state, but also I think does occur in this form of psychosis. So what you're asking yourself is, given this person who's come because of emotional problems or whatever it is, how do I explain what is being observed? And therefore, how do I intervene in a manner that is likely to be effective? And that requires proper assessment and a formulation. Now, as part of the mental health initiative we're doing, we've just had our first meeting, and we're trying to construct these sorts of diagrams that help provide what I would see as a conceptual framework for how you think about mental health in this population. So at the top here, really, it's much more about well-being. It's about the circumstances where the person lives. To what extent is it a Prader-Willi appropriate environment that helps the person feel safe and able to thrive? But then, of course, there may be, in the context of the atypical brain development that I've talked about, a number of other problems that are well recognized in people with Prader-Willi syndrome, such as what we've called here behaviors of concern, the hyperphagia and so on, but also what may be seen more and conceptualized as a mental illness, from affective disorders to psychotic illness. And it's this formulation that ultimately leads to intervention and to improvements in well-being. And much of the intervention in this field is around the environments where people live. And that there are different frameworks that you can use to think about these things, from applied behavioral analysis. You need to think about it from a more biomedical perspective in terms of, are there comorbidities? You can think about it developmentally. Are these behaviors that would be expected among people with Prader-Willi syndrome? And systemically, in terms of the environment, is there food security, and so on. And I want to end with this model, because for me, this has really helped me think about the issues. So you've got the genetics of Prader-Willi syndrome that leads to atypical brain development and dysfunction, if you like. And I think we've got three pathways here that are really important. I think from the point of view of the hypothalamus, you've got impaired regulation that I talked about that includes food, and that's about impaired homeostasis. You've also, I think, got a different pathway, and that's probably much more cortical, and it's about impaired cognition, the ability to understand the environment and understand what people's emotions and so on, and the ability to respond to change. And then you've sort of got a third pathway, which I think is about psychotic illness. So there are, if you like, what I've loosely called here, biological interventions that may be helping different aspects of what's going on in the brain. But of course, so much of what we do is about the environment. It's about looking at what factors may have maintained these behaviors, looking at the present environment. Is food security there or not? And it's looking at, particularly when it comes to early intervention, are there ways that we can help people with Prader-Willi syndrome acquire the skills that later allow them to cope with change more effectively, and so on and so forth. So I hope this has given you a way of thinking about mental health and behavior problems among people with Prader-Willi syndrome. It's probably not giving you the solutions, but if you can understand them, then I think you can get a long way to coming up with the solutions yourself. So thank you very much. I'm sorry I slightly ran over time. I think I apologize for that.